Dr. Ghazi Sakr is a leading urologist with a focus on minimally invasive surgery and men's health. He serves as Program Director of Urology at the University of Balamand and head of the Urology Division at Mount Lebanon Hospital University Medical Center. He completed his urology training at AUB Medical Center and pursued advanced training in England, specializing in laser and minimally invasive urology. Dr. Sakr is an associate member of the British Association of Urological Surgeons and also a member of the European Board of Urology and the International Urology Society. He has authored several publications in the fields of urological cancers and advanced surgical techniques. Dr. Sakr is especially dedicated to men's health after age 50, addressing conditions such as andropause, impotence, prostate cancer, and their connection to broader health risks. His work combines surgical innovation with preventative care to improve quality of life for aging men.
It's a pleasure to have Dr. Ghazi Sakr with us today. He will address the topic of men's health. Where are we now? تفضل Dr. Sakr.
Good afternoon. I would like first to thank the LOP in Tripoli for inviting me to speak here. And I'll be speaking about men's health. Men's health, why do we need to speak about men's health? Okay, why does it matter? Men at 50 are still active. With the advancing age of marriage, they still have people that are dependent. So we have our children at 15, 17. So they have to still to be active and maintain their health. Okay? So they have so many things to worry about. We have the heart disease, we have high blood pressure, diabetes, osteoporosis, weight gain, muscle loss, all these things. Mental health issues as well. But for us urologists, there are three main things that we look at. We have the andropause, impotence, and prostate health. So this is my outline: andropause, prostate health, and impotence. Over the next 15, 20 minutes, I'll try to, sum up these things because this is really a new field and subject. It's just been addressed really over the past few years. So, andropause. In women, menopause is evident. She knows, well, she's in menopause. Whereas for men, andropause is stuttering. It just comes slowly. And why does it happen? Actually, with aging, there is an increase in sex hormone-binding globulin that is synthesized by the liver. And hence, it binds the testosterone, and the availability of circulating testosterone decreases. Most of it is bound to this binding globulin. And this is just a graph showing the median testosterone in relation to age. Starting age 30, it starts to decrease, whether we like it or not. But it varies from a man to another. This is, again, another graph just showing you the testosterone level, how it decreases with age. Okay, what are the symptoms of andropause? It's just fatigue, low libido, and mood changes. بصير ما له خلق يعني, as simple as this. إنه حلوا عني. And he doesn't know why. And we just feel it. Okay, how do we prevent andropause? Actually, it's just lifestyle. Exercise, what we eat. We have to sleep well, decrease smoking, weight management. This is one way of, delaying andropause because it is bound to happen at one age. Some feel it at 50, some feel it at 70 or 80. Okay, how do we diagnose andropause? There are three things we look at: the symptoms, the level of testosterone, and of course we have to rule out other conditions that causes the symptoms, like thyroid malfunction, depression, and what have you. Now, how do we treat andropause? As we said, lifestyle modification. We can replace testosterone, And we have to monitor the risks of testosterone replacement. Okay, now, a few words from the AUA about testosterone. It's just not enough to have one level of testosterone. The level of 300 should be measured 2 times in the morning. And of course, we should have symptoms associated. Without symptoms, really, it's not very significant. Now, whenever we want to replace testosterone, what does the AUA says? Look, low testosterone is a risk for cardiovascular disease. And whenever we replace testosterone, we get improvement in many functions like erectile functions, the low sex drive, the depressive symptoms. But the long-term impact of replacing testosterone on spermatogenesis should be discussed with the patient because we will lose spermatogenesis, and this is a grade A level of evidence. Now, whether a patient on testosterone replacement will develop prostate cancer, so far, there is no evidence for this. No, testosterone replacement will not cause prostate cancer. However, if somebody has prostate cancer, we have to be really careful in replacing testosterone. Okay, and these are some other side effects of testosterone replacement: the acne, breast enlargement, smaller testes, sleep apnea. We can have some thromboembolic event, and of course, we have decreased spermatogenesis. What are the available testosterone? These are the available testosterone. I'm not going to go over them. In Lebanon, we might have just one form of like intramuscular testosterone, but the pellet, the replacement, and these, varies, and they vary the way we give them, whether with a patch, whether it's an injection, or a depot. Okay. Now we move to prostate health. We have, of course, the benign prostatic hyperplasia and the prostate cancer. I'm not going to go over the benign because, again, it's a very long subject. We'll focus mainly on prostate cancer. It's a very common cancer. It is the most common cancer in man. And the risk factors include age, family history, and race. Okay. This is just an incidence of prostate cancer by age. This is from the UK. And you see it is very common. We cannot prevent prostate cancer. Of course, we say like a healthy lifestyle might help, but we don't know. And some study urologist note says that 5-alpha reductase might help in some prostate cancer, but then again, the evidence is not that clear. Okay, how do we diagnose prostate cancer? Of course, we have the combination of the blood test, the prostate-specific antigen, and we'll be speaking a bit about the screening of PSA that is controversial. Initially, they said like everybody should have a PSA, but then again, cost effectiveness issues, etc., stopped it. So we urologists, we like to have PSA because we can do something about localized disease. But on the other hand, are we treating non-lethal cancers? That's why, they're pushing for us as not to do the screening with PSA. Are we doing unnecessary biopsies on these men? Okay. So now, just a few words about the NCC guidelines on PSA. So they say that a PSA level at the age of 40, should be done at 40, 45. And annual testing is reasonable in high-risk men. Now, we'll see who are the high-risk men. And a velocity of more than 75 per year, a change in PSA of more than 0.75 nanograms per milliliter over a year, or more than 25% increase is considered suspicious. And we should stop routine screening in men above 75, also on those men whose life expectancy is less than 10 years. Okay? We're talking about screening يعني somebody who doesn't have anything, عمره 75, we just don't do PSA. Okay. If somebody comes to us and says, look, I want to have my PSA done, we cannot refuse it. And this is, again, from the NCC guidelines. So we have to do PSA on those men who are coming for screening, whatever, regardless of age, etc. But again, we should tell them what are the pitfalls of these. The high-risk individuals, we have the African descent, the Lynch syndrome that is associated with so many cancers, a family history of prostate cancer, especially the first siblings, and if you have a high PSA density of 0.15, and of course the BRCA1, BRCA2 germ lines. How do we diagnose it? Again, we have nowadays the MRI. The MRI has become, in the guidelines, we do what we call a multi-parametric MRI of the prostate that give us a PIRAT score from 1 to 5. And this helped us really to avoid unnecessary biopsy, and it allowed us to do targeted biopsy on the lesion. The PIRAT scoring, just for us to know that a PIRAT 5 is very high risk to have a clinically significant cancer, whereas PIRAT 1 is very low. And this is an image of a multiparametric MRI where we can see the lesion and we can send a needle into that lesion and take a biopsy from it. Of course, now we recommend also doing biopsies all over the prostate, more than the targeted lesion. This is just the cancer detection rate for PIRAT scores. It's not 100% for PIRAT 5. It's not 0% for PIRAT 1, okay? So yes, there is a risk, but the risk becomes very low in low PIRAT scores. We have also the PET PSMA. PET PSMA is highly specific and sensitive. It is very useful in diagnosis, in metastatic workup, and in biochemical recurrence. That is when the PSA comes back after treating the cancer. And in biochemical recurrence, it's recommended to do a PET if the PSA level is 0.5 nanograms per milliliter, but it can detect some cancers for levels as low as 0.2. Okay, this is an example of PET PSMA. All these tiny lesions that are seen all over the body can be missed by other diagnostic techniques. Okay, this is just the risk group for biochemical recurrence. In prostate cancer, just the urologists know this. You have the low risk, the intermediate, favorable, and unfavorable, and high risk. I'm not going to go over these. And for us, it is important, to know the localized disease and the locally advanced disease, because with the advance of treatment in prostate cancers, we are able to do a lot. Like when I trained, we didn't have anything. Okay, the treatment. For low risk, from the table we just saw, we can do something called an active surveillance. Just we do nothing, and we just observed the cancer, how it's growing with follow-up, MRIs and biopsies at 1 year, etc. And there is something called focal therapy, where we just, target the lesion and destroy it. For the localized treatment, we have two options. We have the radical prostatectomy. We have radiation therapy in combination with androgen deprivation therapy. And the results in both are equivalent, around 90% disease-specific survivors, though we surgeons, we like to operate. Okay, now, radical prostatectomy can be done open, laparoscopic, or robotic. And of course, the results in disease-specific survival in all three modalities, if well done, are the same. But of course, the robotic has advantages. Now, Dr. Mahdi has alluded to, less blood loss. We can preserve potency much better, as we can spare the nerve of erections, of course, the pain, and the hospital stay. Radiation therapy has advantage, as we don't need to anesthetize the patient. We usually use it for older men at anesthetic risk. And it's important to know that we can always, after a radical prostatectomy, do a radiation therapy. However, the reverse is not true. Okay? نحن surgeons, we like to operate. Okay, now for metastatic disease, the mainstay of treatments is anti-androgen. In the past, when I trained back in the 90s, early 90s, we didn't have anything except the orchidectomy, just to remove the testes. Nowadays, we have the agonist and antagonist, LHRH agonist and antagonist, in combination with novel anti-androgen. And with these, we have a major improvement in survival. Like somebody's coming with a metastatic disease to bone, etc. We have something like 6-7 years of survival, which is very good. And chemotherapy, also we have chemotherapy, and usually chemotherapy is reserved for the high volume disease in combination with the anti-androgen. Novel treatment, we have the cancer vaccine, that's too expensive. Immunotherapy, we have the checkpoint inhibitors again, and we have the PSMA targeted therapy with lutetium-177. All these are ongoing work. We have some good results. We don't know on whom we are going to give these, but then again, these are very expensive or available in Lebanon, except the Sipuleucel, we don't have it, but then again, these are investigational. Time. Now we move to the impotence. So impotence, it's defined as an inability to achieve and maintain erection to complete the sexual act. So what is the reason? There are 4 reasons, actually. We have the vascular, like, the vessels are blocked. We have neurogenic, due to the nerves, hormonal, low testosterone and sexual drive, and we have also the psychogenic. And we see it a lot in young people, the psychogenic thing. This is the physiology of erection. I'm not going to go over it. You have the sexual stimulation that releases dopamine, oxytocin, and goes through the dorsal root, going to work locally down there. And this is what happens down there. We have release of nitrous oxide from the nerve terminals that works on guanylyl cyclase to make from GTP, you have cyclic GMP that causes the relaxation of the smooth muscles, and you get the erection. Okay. How to prevent it? Again, healthy lifestyle, like any other disease. So a healthy lifestyle, regular exercise, and of course, maintain our brain within our head. Okay. How do we diagnose it? We have, of course, the history and the physical exam. We have a test called the nocturnal penile tumescence testing. And, of course, in the labs, we do the testosterone, glucose, lipid, to look for the risk factors. How do we treat it? Lifestyle changes, risk factor control, sports, whatever. We have also medications. We have the mainstay, really, is the PDE5 inhibitors that work, I will show you this, that work here. Oh, wait, no. Okay, they work here. They prevent the breakdown of cyclic GMP. So they almost replicate the natural thing. So we'll have more cyclic GMP available to work on the relaxation of smooth muscles. And we have 3 main medication. We have sildenafil, vardenafil, and tadalafil, and they differ in the length of work, the time, the duration. If testosterone is deficient, we can replace testosterone. And for those patients, we can use some anxiolytic like bupropion that increases the level of dopamine and norepinephrine. We have also the injections. These are intracavernal injections. We have, prick the papaverine, we put it into the corpora, and we get an erection. We have papaverine, phentolamine, and Caverject, which is a PGE1 agonist, and Trimix, which is the combination of these three. What else? We have intraurethral pellets of prostaglandin. We can just put them into the urethra. These are associated with some urethral irritation, etc., but they do work. We have, again, the penile implants. We have the semi-rigid. We have the inflatable 2 or 3 pieces, and they work. We have also vacuum devices where you just apply this to the penis. It drags blood into the penis, and with a band that keeps the blood into the penis, and the patient performs. Now, I have to talk about this, though it didn't give anything, because here in Lebanon, they use it a lot. But again, it's not FDA approved. They get this PRP, and there are so many trials on PRP for erection, and it didn't work. It's not better than placebo. So in conclusion, the conditions I talked about are very common. They are underdiagnosed. Many a times we do get a lot of patients with metastatic prostate cancer. We get patients, they are sent bieħdu anxiolytics, and they have testosterone deficiency. And general physician, non-neurologist, they play a key important role in diagnosing these patients. Thank you.
Thank you very much, Dr. Sakr. Thank you.